photographs of yesterday program. Na?
Yeah, I got. Okay, sir.
The photographs which was clicked by cameraman we will be getting in 2-3 days.
Okay. So they'll be posting in the group.
Yes, we will post in the group.
Okay.
Ma'am, we are live now. Let me share my screen. Good evening, respected faculties. On the behalf of Corona Remedies, this is Piyush Shukla. Welcomes you all in Indian Fertility Society, Art and Gynecology, Art and Endoscopy, IFS Chhattisgarh chapter with SIG Endoscopy and Bilaspur OBGY Society. With no further delay, as the tradition goes, I'd like to start the program with lamp lighting ceremony followed by a Ganesh Vandana.
Okay.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
It is always a pleasure to have God's blessing before starting any program. With no further delay, I'd like to welcome Dr. Sushpa Verma ma'am, and let me introduce her with the brief introduction about her. She had tremendous work experience working as a director and consultant at Sarvodaya Hospital Test Tube Baby Center. Worked as consultant at Ayushman Endosurgery Center, worked as consultant at Gayatri Hospital, and extremely a lot more. Member of FOGC since 2000, executive member of IFS, executive member of ISAR, active member of ROGSI, a lot of badges under her belt. I'd like to invite Dr. Sushpa Verma ma'am to please proceed forward.
Thank you, Piyush, for the warm introduction. Good evening, everyone. With great pleasure, I want to welcome you all on behalf of IFS CG chapter to this webinar on ART and endoscopy. This webinar is organized by IFS CG chapter in association with SIG Endoscopy Committee and Bilaspur OBGY Society. With due respect and gratitude, I want to welcome and thank Dr. K.D. Nair sir and Surveen Guman ma'am for this wonderful opportunity. And I want to thank and welcome respected Abha Singh ma'am and Prakriti. It is due to their focused vision that we are able to organize such a wonderful webinar on a very important topic. With great respect, I want to welcome Kuldeep Jain sir, mentor of SIG, who has strongly projected the role of endoscopy in ART. And I want to welcome Dr. Punita Bharadwaj, convener, and Dr. Priya Bhave and Mansi Jain, co-convener of SIG, who took so much efforts in organization of this webinar. And I want to welcome Dr. Rashmi Sharma ma'am, Dr. Pratibha Makhija for their constant support and cooperation. And I want to welcome wholeheartedly our speaker again, Dr. Kuldeep Jain sir and Dr. Mansi, who took time from their busy schedule for their and ready for their scientific deliberations. I want to welcome our chairperson, Dr. Pratibha, Dr. Rashmi, Dr. Sangeeta Sinha, Dr. Priya Bhave, and our panelists and moderators who agreed to participate in the webinar and share their knowledge and experience. Now, I hand over the program to Dr. Ishpreet to proceed to the program further.
Good evening, everyone. Thank
Good
you,
evening.
Sushma ma'am, for such a kind words and giving me this opportunity for coordinating with you for conducting this webinar of today. Without further any delay, let's start the first session by our speaker, Dr. Kuldeep Jain, sir, Demystifying Fibroids. For this first session, I would like to invite the chairpersons for first session, Dr. Priya Bhave Chittavar and Dr. Sangeeta Sinha. Dr. Priya Bhave Chittavar, as we all know, she's a consultant and head Department of Reproductive Medicine, Bansal Hospital, Bhopal, and FNB Reproductive Medicine teacher and ex-faculty of DM Reproductive Medicine. She's a FOXY recognized trainer in basic and advanced infertility management and a Cochrane reviewer and author. And as we all know, she's an iron lady who have recently run a marathon on Mumbai of 42 kilometers. Who don't know her? And secondly, we invite Dr. Sangeeta Sinha, ma'am. She is a well-known infertility specialist and she has a very successful laparoscopic center running at Bhilai. She is working as a PG in, she has done a very, so many, kitties in her, so many awards in her kitties. And she's DGO Obstetric and Gynecology from Patna, India, and Director of Revival Medical Center, Bhilai, India. We welcome you, ma'am.
Yeah, hi. Hi, everyone. So should we start the
Ma'am,
session?
can you invite our speaker, Dr. Kuldeep Jain, sir, for his lecture?
Is Dr. Priya?
I think Dr.
there?
Priya has not joined. Ma'am, please introduce our speaker, Dr. Kuldeep Jain, sir.
Hi, everyone. Hello.
Piyush, can you show the CV of Kuldeep Jain, sir?
Yes, ma'am.
Hello.
Hello.
Am I audible?
Yes, ma'am,
Yeah,
you are
Sushma,
audible. Yes, ma'am, you
am
are
I
audible.
Yeah, is
Yes,
Dr.
yes, ma'am.
Priya?
You are
Yeah,
audible.
Dr.
Ma'am.
Priya is there. Yeah, can someone
I think Priya,
share
Dr.
the
Priya has not
CV of
joined.
Dr. Kuldeep Jain, sir?
Yes, ma'am, they are trying.
Okay. Can anyone please share the CV of Dr. Kuldeep Jain, sir? Kuldeep Jain, sir, has joined.
Yes, sir. Yes, ma'am, he has joined. Dr. Kuldeep has joined.
Sir, good evening. Kuldeep Jain, sir, good evening.
Yeah, I'm doing.
Ma'am, actually, ma'am's network is quite slow. That's why she cannot read screen.
Okay.
Can you
Piyush,
please
if you
share
are
the
having CV, if you are having CV of Dr. Kuldeep, then please you can read the CV at your end.
So moving further session, at first, I'd like to introduce with you all for the first speaker, Dr. Kuldeep Jain, sir, mentor SIG, past president IFS, and a tremendous personality with so much of experience under his belt. I'd like to invite him on the dais to please proceed forward. Ma'am, on Kuldeep sir's and he also has some issues with network.
Okay.
Okay, sir is not joined.
He has joined, but he is facing some issues.
Some network issue. Okay.
Ma'am, Dr. Kuldeep will take time in relocating. He's facing some network issues. So I think I can take my lecture first. So we'll be saving on time, if that's okay.
Yes, ma'am. Yes, Mansi. Mansi, can you start your lecture?
Yeah, sure. I'll just give me a minute. I'll just share my screen. Okay, is my screen visible to all?
Yes,
Should I
ma'am.
introduce Dr. Mansi Jain before she takes her lecture? Hello. Hello, everyone.
Hello.
Hello. Should I introduce Dr. Mansi Jain before she starts her lecture?
Yes, ma'am.
Yes, please.
Yeah.
go ahead.
Yeah, she is going to speak on pre-ART histoscopy. Is it mandatory? She is MS in gynec and she has done diploma in clinical ART and she has got fellowship in reproduction and medicine and surgery from Singapore. At present, she is consultant at KGIF and Lab Center, Delhi. She has been co-convener in SIG Endoscopy IFS 2022-24. She has presented many papers in international and national conferences. And she is keen academician and research with special interest in reproductive medicine. She has got also second prize in paper presentation in ISA 2016. So I invite Dr. Mansi Jain for her talk on PRT histoscopy. Is it mandatory?
Thank you, madam, for the kind introduction. Over the last few decades, there have been several advancements in the field of ART. Despite changing our protocols, getting new modifications, despite increasing the number of M2 oocytes and obtaining good quality embryos, the pregnancy rates, however, still continue to plateau at around 45 to 50%. Well, clearly, implantation is a rate limiting step in IVF. You will be astonished that if you do a PubMed search, there are over thousands of research articles on embryo alone, but very few on endometrium. A very warm evening to all. I'm Dr. Mansi Jain, and on behalf of SIG Endoscopy, it is my pleasure to welcome you all for today's webinar. So today I'll be speaking on a very hot controversial topic, that is pre-ART hysteroscopy mandatory? Well, let's start with the basics. Why to evaluate the uterine cavity prior to ART or IVF? Our current scope of infertility treatment is plainly limited. What we actually see is only the tip of the iceberg, which may be expanded by the use of combination of modalities like TVS and SIG, etc. However, the major chunk of portion we are not able to see. So why hysteroscopy? Well, I think the answer is very obvious because it provides direct visualization of the endometrial cavity and also provides the opportunity to correct the abnormality in the same sitting. We all know it's a simple, minimally invasive and relatively safe procedure, and it also helps in counseling of the patients better. So does the intracavitary lesion affect the outcome? I think the answer is well established. We've got several studies which show lesions like endometrial polyps and submucous fibroids, they do affect the reproductive outcome. But what was a bit surprising is that we've got studies which clearly state that around 26% of the patients with normal HSG or normal ultrasound findings have abnormal hysteroscopy findings, and the correction of this has led to increased pregnancy rates. Some even say the detection of uterine pathology in hysteroscopy is almost up to 18 to 50%, and there is a significant difference in the pregnancy rates between the abnormal and normal hysteroscopy findings. Then for patients going for IVF alone, 45% of the patients were detected with abnormal uterine findings, and correction of abnormalities like septa, small polyps, uterine synechiae in patients with normal HSG findings have led to an improved pregnancy rate. So possibly hysteroscopy can help us in inverting this pyramid. Because after all, it's about selecting the right seed for the right soil. So I think it is very well established about the role of hysteroscopy. So that is not really the topic of debate here. What the debate really is that should it be offered to all patients as a blanket going for ART procedures, or it should be left for a selective few? So to make things more streamlined, let's divide it into two groups. The ones where the pathology is detected and is correctable, well, that group is less debatable. Yes, they do require hysteroscopy. However, there is a strong debate in the cases where no pathology is detected. So let us look at the evidence. Well, we've got very low quality evidence stating that it is unclear whether hysteroscopy performed before ART, regardless of intrauterine abnormalities, does improve the live birth rate. We also have moderate quality evidence suggesting hysteroscopy does increase the pregnancy rate if performed prior to IVF, regardless of intrauterine abnormalities. Again, for submucous fibroids or endometrial polyps, we do have moderate quality evidence that hysteroscopy may increase the pregnancy rates. However, no studies were found which look directly at the live birth rate correlating hysteroscopy. So in the end, robust and high quality RCTs are still needed before we label hysteroscopy to be mandatory as a first line procedure. We've got a few studies which are in favor that it should be done, like this study from 2005, which recruited around 300 patients and concluded that patients who underwent a pre-IVF hysteroscopy, there was a significant increase in the pregnancy rates. which was around 38% as compared to the non-hysteroscopy group where it was 18%. We've got another study which documents the importance of routine office hysteroscopy prior to ICSI, suggesting there was again a significant improvement in the implantation and the pregnancy rates. We also have a meta-analysis from 2013, which advocates the use of hysteroscopy prior to the first cycle of IVF, and they concluded that there was a significant increase in the cumulative pregnancy rate and the live birth rate in the hysteroscopy group. However, the practice committee of ASRM does not agree with this. It clearly states that yes, hysteroscopy is considered the gold standard for evaluation of the uterine cavity. However, the first line investigation tools should be limited to the indirect imaging techniques like the TVS, HSD, and SIS. And NICE guidelines are also in agreement, which consider hysteroscopy to be a second line procedure, should be reserved only for patients with detected abnormality due to its invasive nature and cost. ESHRE also has the same recommendations that hysteroscopy could be useful for confirmation and treatment of a suspected uterine pathology and should be reserved as a second line investigation. So this is our approach at KJ-IVF for patients of hysteroscopy. As a routine practice, we do hysteroscopy only in the selected patients and not as a blanket for all patients going for ART. So usually we rely a lot on TVS, 2D ultrasound, and most of our diagnoses are made on the ultrasound itself. However, having said that, we also do take into account the HSD if the film's available, and in special cases we may consider SIS. So, but a good basic 2D TVS scan is must to reach any kind of diagnosis. And recently, we have started using a lot of 3D ultrasounds as well, as you can see in these pictures. So the role of 3D comes in where, you have these myomas, which are a bit tricky to diagnose if they are getting inside the cavity, if they're indenting the cavity. So this is where 3D really helps. We have started using it routinely along with the 2D. So it's very good for, especially for mapping of the fibroids, and it does help, getting the right and avoiding hysteroscopy in many of the cases. Also, like I said earlier, in very selected few patients, we were doing SIS also, but again, because of the introduction of 3D ultrasound, it's more of 3D now than resorting to SIS. So this is the correlation. These are pictures of intrauterine adhesions. You can see how beautifully one can diagnose these kind of cases on ultrasound itself. And this is the hysteroscopy picture. So I would say only for a selected group we go for hysteroscopy, which includes patients with poor endometrial growth, patients having history of prior COX, an obvious abnormality on TVS, on HSD, repeated IVF failures, and history of repeated abortions. So I would like to show a couple of really interesting videos here. They're very short videos. Like in this first case, it's a very old video, that's why the quality is a bit compromised, but you will be able to notice there are flimsy adhesions on the fundus with the focal area of atrophy and pinpoint ostia. So these are the cases which can be easily missed on ultrasound, but they do affect the pregnancy rates. Like in this Second case also, there is fundal scarring, again with the pinpoint ostia. So these are the cases which do they do warrant a hysteroscopy for correction. Like in this case, you'll be able to notice the multiple thin flimsy curtains of adhesions which are running along almost in the entire upper cavity, and this is something that can be easily missed on ultrasound. So when this patient had come to us, she had already had 3 cycles of IUI, and we decided to take her up for hysteroscopy, and this is the kind of picture that we got. So hysteroscopic dysiolysis was done in this case. It's a very relatively very easy procedure if done correctly, and very satisfying with very good results. Move it a bit forward. So this is how the cavity looks at the end of it. Now, this is a rather interesting short clip of grade 4 endometritis. Can be very tricky because in this particular case, only 20% of the cavity was visible. I say it's tricky because in these cases, you need to get the plane of dissection right. We all know the complications are perforation and fluid overload. So, but once you get in the right plane, the cavity sort of opens up itself, and the aim in these cases should be to reclaim as much of the cavity as is possible to give the patient the best shot at conceiving. Also in these cases, like I said, perforation is a big risk factor. So using intra-op ultrasound guidance may be a good, I mean, we do it often. In cases of doubt, it's always good to use the ultrasound machine. And in these particular cases, the follow-up is very important, especially post-op dysiolysis prevention. No clear-cut guidelines are available. We use estradiol. Especially in these cases, should be given at least for 4 to 6 weeks, and the follow-up of the endometrium is very important. These cases may require a second look surgery. This again is a very interesting case. So on ultrasound, we could see hyperechoic calcific areas which were scattered all along the cavity with no significant previous history. So when we put the scope inside, you can see we saw these bone pieces which were remnants from previous incomplete abortion scattered all along the cavity. So we remove total of all these pieces. Then we have the obvious defects. This is a broad base septum. Septal resection was done. Let me just skip this forward. Then we have these small polyps, again, a bit controversial. Should they be removed? Should they be left intact? And submucous myomas. So I'll just move on to the next slide. This is our analysis. This is a little bit old data from the year 2000 to 2017 to 2018. A total of 520 cycles were done. And out of this, patients with first cycle were 383. Out of this, hysteroscopy was done in 81 of the patients. You will be really surprised to note the other group was patients with at least one IVF failure. That was around 137 of patients who had already had a previous IVF failure, and hysteroscopy was done in all these patients with significant findings in 130 of them. So this is a bit alarming data. It really leaves us wondering, once it makes you ask that should we really wait for a failure to act further? Then again, this is our statistics. So this is pregnancy rates compared in different groups. The one without hysteroscopy, obviously the pregnancy rates are a bit higher. And then we have the groups with the failure. Again, with findings with hysteroscopy correction, the pregnancy rates were higher as compared to the other group. The most common abnormality pathology detected on hysteroscopy was endometrial polyps, which was closely followed by endometritis. So coming on to the second half of the debate, for patients who have already had a IVF failure, well, in those, the role of hysteroscopy routinely is less debatable as compared to the primary group, where there is still a strong debate. So when we look at the evidence in favor of hysteroscopy in IVF failure patients, so we've got 2 RCTs which document the role of hysteroscopy prior to IVF in IVF failure patients, as it increases the pregnancy rate significantly. Also, we've got this study where they conclude that women with repeated implantation failures after IVF have a remarkably high possibility of achieving pregnancy after hysteroscopic evaluation. Then again, there is this study from 2008, which says repeated IVF XCET failures, they have a higher pregnancy rate when hysteroscopy is done routinely before proceeding for the next cycle. However, this is a very big multicentral RCT, which strongly says that outpatient hysteroscopy before IVF in women with normal ultrasound does not improve the live birth rate, irrespective of the previous IVF failures. And this is a relatively recent one from 2016. So I would like to conclude by saying that there is no doubt that hysteroscopy is the gold standard for visualization of the endometrial cavity and for treating the intrauterine pathology. But now there is a growing school of evidence advocating its routine use prior to IVF. Suspected intrauterine pathologies and repeated IVF failure, and our experience also supports the use of hysteroscopy for all suspected uterine pathology prior to IVF. But for the routine use, the debate still continues, and there is a need to develop guidelines for the use of hysteroscopy on the basis of the available evidence. Thank you.
Thank you, Dr. Bansi, for the nice presentation. You have covered all the aspects, all the pros and cons of hysteroscopy in IVF. It was nice presentation. You have shown good videos also and given good data from your hospital also. It was very good presentation.
Thank you, ma'am.
Thank you, Dr. Mansi, for your wonderful presentation. All the videos were very informative, and the one that with the fetal bone scattered all over the endometrium, that was really a new learning for us. And let's move ahead with the next session with Dr. Kuldeep, sir. There. Hello.
Yeah, I am.
Kuldeep?
Yeah.
Okay.
So may I have the honor to welcome Kuldeep Jain, sir, the stalwart of IVF as well as laparoscopy. Welcome Kuldeep Jain, sir, to the webinar of IFS. and as well as Bilaspur Society. Dr. Kuldeep Jain sir is the director and IFF specialist of KGIF and Laparoscopic Surgery Center, Delhi. Sir is the program director of KGIF ART Center, Faridabad, as well as Indirapuram. Sir is the founder, secretary, and past president of Indian Fertility Society. We all know how much input he has given in the Indian Fertility Society. He is the chairperson of International Exchange Committee, IFS, editor-in-chief of Fertility Science and Research, instrumental in convincing and introducing multiple projects in IFS like ISRE preparatory course. Yes, we all owe for that, sir. And we've done lots of other preparatory course also. Brought ISRE campus course, IFS's World Congress and Fusion, Joint Conference of ISRE IFS ISAR to India, Chairperson Endometriosis Committee FOXY, Chairperson Fusion 2022, Board of Directors 2016 and 2019, Member Scientific Committee IFFS. Sir is the Chairperson Infertility Committee AOGD, Member Endoscopy Committee AOGD, and he has delivered more than 200 invited lectures and orations, recipient of Appreciation Award from IFS, IMA, DMA, and FOXY. So over to Kuldeep Jain sir for a lecture over the fibroid. Welcome, sir.
Thank you, Dr. Sangeeta, for your words.
Hello, sir.
Can
Good
you
evening.
hear
Can
me?
I add one more thing, Sangeeta ma'am?
Yes,
It
yes,
was
sure, Veronica.
under Dr. Kuldeep sir's presidentship that IFS Chhattisgarh chapter was installed in 2013.
Yes,
So
he was
this
the
credit also goes to sir.
sorry.
I
And
am
really,
really
we were
happy.
very close to Chhattisgarh, sir.
I am really happy to join this program by IFS chapter Chhattisgarh. Yes, whenever I speak to the forums where I have introduced the IFS, it really adds to the pleasure. So congratulations, Dr. Veronica and Dr. Sangeeta, for taking all ethos of IFS to a high level. Congratulations. I am
Thank you,
really
sir.
happy
Thanks.
to
Thank
join
you,
this webinar, especially hosted by SIG Endoscopy and the IFS Chhattisgarh chapter. Today's topic is very important topic as far as the infertility management is concerned. Myoma, they have been very common incidents in reproductive age group, and patient with myoma, they do and again get pregnant. Okay, so as far as the myoma and fertility is concerned, the debate and controversy is always there. Whether the myoma is really causing infertility, how much it contributes, if it contributes, how does it contribute, and once you find a patient of infertility with myoma, whether it is a concern, whether it should be removed or not, if it is to be removed, how it is to be removed. So there are a lot of things to cover in this topic. There is no conflict as far as the interest is concerned regarding this lecture. Now, so in today's agenda, in next 20-25 minutes, I am going to cover these important aspects regarding the myoma. Which myoma should be removed? Can classification helps in decision making? What route we should take? What are the various principles of surgery and what are the recommendations? So coming on to this great question, are myoma a cause of infertility? Debate continues, but there are certain factors which we need to keep in mind. It is very difficult to prove causal relationship, and in a review, large review, pregnancy rate of 50% after myomectomy in fertile patients has been documented. So there is some relation. If we can say, we are not able to prove it, direct relation, because there are no well-controlled RCTs. There are no clear description of size. What are the size, number, location, which really affects the fertility. Again, there is no standardization of diagnostic methods and result varying between 10 to 70% after myoma. So these are some of the things which we need to keep in mind. Now, there are various theories how myoma can interfere. I'm not going into the theoretical detail, but these are the things which comes into mind. Anywhere there is a myoma, it can cause uterine contractility, and that is how the implantation process can be disrupted. Then there is a discontinuation due to focal endometrial vascular disturbances. Again, all theories, they are related to somewhere related to implantation process. Once the implantation occurs, the chances of carrying a pregnancy with myoma may be better. Then there is defective calcium extrusion, myometrial irritability, and hyperactivity. So these are some of the theories which are put forward regarding the myoma and infertility. Now this picture is mind-boggling. Myoma, you see, they come in various size, shape, all types of patients, they are there. So as a clinician, you need to decide which myoma should be removed, which should not be removed. Like, see this myoma, this picture here. Myoma is quite big, but should it be removed or not? Because it is just slightly indenting the cavity here. You can see, so this is a debatable case. Again, this patient, a myoma sitting just indenting here the cavity. This case having multiple myoma, but cavity is intact, should it be removed? So in our practice, these questions, they do arise. And as a clinician, we need to decide, and how to decide, whether you should take size into consideration, site into consideration, or number into consideration, or all three along with the relationship with the cavity. So I think we need to keep our mind open. It is not a fixed thing. You have to see the relationship, the cavity, previous history, and a lot of other things need to be taken into consideration. Now, as far as the surgery is concerned, or intervention in myoma is concerned, what is the aim? Aim is to preserve and improve the fertility, minimizing excessive bleeding, and relieving pain. So if your surgery is going to help you in these three directions, you can go ahead. If there is no definite benefit, then you need to think twice. And for that, you need to evaluate, classify myoma. Mapping is very important. If you have done a good mapping, you will be wiser in making the decision. So whether to remove myoma or not, mapping is important. Where is the myoma? How many myomas are there? Where all they are sitting? How much they are indenting into the cavity? Whether they are disturbing the cavity or not? So mapping is very important, and that can be done preoperatively by transvaginal sonography, SIS, MRI, but transvaginal sonography remains the gold standard. When you cannot map properly with transvaginal sonography, you can take help of MRI. Now a word about the classification. This is the FIGO classification, which is usually used to decide the location as well as which route you need to go. So starting from 1 to 7, you can classify before starting putting a knife, and you can manage them very well. This is another classification. Classification is very important in deciding the treatment and route. So if you are having a myoma in the cavity, how much it is protruding and how much it is inside the myometrium, that gives you an idea how difficult your surgery is going to be. This is another classification called step W classification, which goes into little detail and scores it. And this classification can give you direction how difficult your surgery is going to be. Like if you are scoring 0 to 4, it is a simple surgery which can be done by hysteroscopy, and the patient is usually behaves very nicely post-operatively. If you are having a higher score, the complexity increases, and 7 to 9 hysteroscopic myomectomy is not indicated. Now, this is just a guideline. If you are comfortable, if you are a very good surgeon, if you have done a lot of surgeries with 7 to 9, you can go ahead, but the risk of complications are quite high. Few videos I will like to show you. The problem comes when the route is not decided, like in this. Video is not working. Just a minute. Okay, the previous video is actually a flap method, which is I will like to show you just after some time. So this is a very simple case, but it is having multiple myoma, uh, exactly 3 large myoma, but they are all type 0, or one myoma is type 1. So they can be easily dealt in the same sitting, single sitting, by a resectoscope, using resectoscope. So this is simplest one, where you can use a resectoscope and do the a quick surgery and remove all 3. Now here, where you are having multiple myoma, if they are anterior and posterior and opposing each other, then certainly there are more chances. So some people say that they should not be removed in same sitting, but if they are not opposing each other, then you can go ahead removing all myomas in same sitting. Now, post-operatively, usually we give only estradiol valerate for a longer period in these cases, and most of the time they are followed by uh, ultrasound and Doppler, and if everything is okay, we can go ahead for transfer. But in those cases where you are finding a irregularity on ultrasound follow-up, then you can go for a second look. Otherwise, second look is not done in all cases. Again, this is debatable question whether second look should be done in all cases post myomectomy. My practice is I always use Doppler as well as 2D ultrasound to decide whether I need to go for a second look or not. There is something wrong with this video. Again, this is a large myoma filling whole cavity. Now, small myoma, they may not be challenging, but when you are dealing with large myoma, uh, they may be challenging, and you need real expertise. You need to finish the surgery quickly, so you are not inviting any complication like fluid overload and other thing. So that you need to be very careful when you are dealing with large submucosal myoma. Let's see. Can you give me 1 minute? Let me see where is the problem. Can you see this video now?
Video is not playing, sir.
Yeah. Now can you see? No?
No, no, sir.
Can you see my screen?
Yes, sir. Screen is visible.
Then it should
You
be.
see the picture of the myoma and the loop, but the video is not moving.
Video was not moving.
Yeah.
Now?
नहीं sir. So वो slide share पे डाली नीचे वाले
Because it is running here. You are able to hear.
Anybody else? और किसी को दिख रहा है? वेरोनिका?
मैम प्रेजेंटेशन दिख रही है पर स्क्रॉल नहीं हो रही।
स्क्रॉल नहीं हो रही सर। हाँ।
हाँ।
Video is not moving, sir.
Okay, anyway, I will continue with the presentation.
Yes, sir.
Can you see my screen presentation?
Yes, sir. We see your screen presentation, sir. But it's not in slides here. उसको नीचे से हाँ click कर दे sir.
Okay, so anyway, video is not moving.
Video is not moving.
What I wanted to show you here, the role of vasopressin when you are doing the myomectomy surgery with a large myoma. It is always good. Now we are having multiple tools to minimize complication. Like one of the important complication which always in our open surgery days we used to worry about the loss of blood as well as losing the uterus. So now with the advancement of these technique, we can reduce the complication of hemorrhage by using vasopressin. So it should be used in dilution in consultation with anesthetists, because anesthetists, they always they are again worried about the complication of vasopressin. So a team is very important. Coordination between the anesthesia people and the surgeon is very important for a smooth surgery. Usually we dilute it 200, 300 times to avoid any complications. And this gives a very bloodless surgery. This was a video which I wanted to show, very large myoma of 7-8 centimeter. And this myoma is another myoma which is sitting in the broad ligament. Now, broad ligament myoma, they are again very easy to tackle, but at the same time, because there are a lot of vessels and ureter in the broad ligament, so you need to be very careful when you are dealing with these broad ligament myoma. You need to identify the ureter, you need to identify the blood vessels, and you have to take care of these blood vessels. Otherwise, these myoma can be easily dealt with. Coming on to the evidence, now this is level A evidence that whenever you see submucous leiomyoma, it is well known that it contributes to infertility, and their removal improves pregnancy rate. There should not be any doubt. So when it is you are dealing with a submucous myoma, even if it is small, it is contributing to the infertility, and if the patient has come to you with infertility, you must remove it. It will increase the fecundity in that particular patient. So this is level A evidence. Now, this is a paper from Sis Kamal Sankara. She did a observational study of 6,087 IVF cycles with 19 observational studies, and she found that myoma do decrease the live birth and clinical pregnancy rate, even in those patients where it is not distorting the cavity, it is intramural. But again, this paper is open to debate and discussion. Limitation is there because these are all observational studies. That is the biggest disadvantage of this study. So we cannot just say that if it is not distorting the cavity, you have to remove. But this gives a thought process that up to what level you can leave a intramural myoma, and that is again a debate. Now, size of the myoma does play a role when it is not distorting the cavity. So this is one paper of intramural, large intramural fibroid more than 5 centimeter, resulting in the significant implantation rate drop, pregnancy rate drop, and ongoing pregnancy rate drop. So this is again a paper which favors removal of a large myoma which is more than 5 centimeter, even if it is intramural. This is another paper which I will like to highlight in unexplained infertility. Otherwise, unexplained infertility, the patient is having uterine fibroid. This paper again says significant decrease in the implantation, clinical pregnancy rate, increase in the miscarriage rate, and decreasing the live birth rate. So these two papers, they do say that even if the patient is not having a submucous myoma, they need to be considered, especially in unexplained infertility. You are not finding anything. But this is again a debatable point. How much size? There is a large group which says if it is more than 5 centimeters, you must remove. So what happens to myomas less than 5 centimeters? Now, concluding, submucous myoma, no debate. Intramural myoma is more controversial. And consensus is, if it is 5 centimeters, one must operate before ART, even if it is not distorting. If it is less than 5 centimeters, the pregnancy rate, usually there is not difference, not much difference whether you remove myoma or not. Now, there is another variety of myoma, small myoma, not entering the cavity, but it is just sitting at the myometrial and endometrial junction. Now, these myoma, they do affect, even if they are small, they affect implantation process, and there is a growing school to support removal of these small myomas. So intramural fibroid smaller than 5 centimeters should be disregarded. Should we operate before any infertility treatment? These are open questions to everybody. Should we operate before IVF? Should we operate after IVF failure? And yes, after how many failures? Should the decision be influenced according to the cost of IVF in different countries? These are all open questions which are still under debate. So, dear friends, important take-home messages from my talk. You need to make correct diagnosis. Very important to map myoma, and one has to differentiate it from adenomyosis, because many times it happens that you have diagnosed it as a fibroid, and when you start enucleating it, you find this is not fibroid, it is adenomyosis, and then you are in soup. You are not very confident about doing the adenomyomectomy, and when you compare the skill required between the myomectomy and adenomyomectomy, it is really a great difference. Myomectomy, you are having a very nice plane. You can finish your surgery very fast. It is easier to suture. But when you are doing adenomyomectomy, you require little more skill. You have to provide, because there is even vasopressin doesn't help much, because there is no you have to use large amount of vasopressin to make it bloodless, because there is no plane. So that's why the adenomyomectomy becomes a difficult surgery. You need to plan the route, whether you have to go. You may be very good surgeon, but if you are not planned it properly, you may develop more complications. Minimal bleeding, maintain hemostasis is very, very important for healing. You should not leave any pockets, blind pockets after myomectomy. Otherwise, these patients, they do develop either a very weak scar, chances of rupture of uterus, then post-operative infection chances are very, very high if you are leaving a hematoma there. So you have to maintain hemostasis. You have to suture it very, very carefully. Restore the cavity very nicely if you have opened. No problem if you open the cavity, try not to open, but if you have opened, just close it without including the entering into the cavity. So just oppose it by any sutures which you want. But suturing is another art which you need to learn when if you are planning a laparoscopic myomectomy. Reasonable operating time remains the best way to diminish the risk of adhesion formation. Very important to preserve the cavity, because your patient is infertile. If you have done a myomectomy and patient has developed intrauterine adhesion, it is a criminal offense basically. Minimal adhesion formation should be there. Avoid dead spaces and perfect suturing. Thank you very much for your patient hearing. If there are any questions, I am happy to answer. And again, thank you very much for having me in this.
Thank you very much, sir. It was a wonderful lecture, very informative.
I am sorry for not able to show the video, because my internet connection was not good. So I need to change the system, and my original talk was in my laptop. So I am using this system, and that's why probably it was not coming. Sorry for that.
So thank you, sir. It was very nice and elaborate presentation. Lots of food for the thought.
Sir, I have one question. Can I ask?
Veronica, I have two questions.
Any particular size of the adenomyoma that beyond which we should operate and below which we should wait? Secondly, are principles of surgeries for adenomyoma the same like fibroid?
First question first.
Size of adenomyoma.
Yeah, so size of adenomyoma, there is no clear-cut recommendation as far as the size of adenomyoma is concerned. But usually what is recommended is adenomyomectomy is not the first line treatment for infertility. That is one recommendation which you always keep in mind. Second thing, if your size of uterus is less than 12 weeks, usually primary surgery is not done until unless there is a repeated miscarriage or repeated failure. Then you can take. Larger than 12 week size uterus, whether it is diffuse adenomyosis or a solitary adenomyoma, you can remove, you should remove if your patient is having a difficult conception, history of repeated miscarriage or recurrent implantation failure. So I always prefer to suppress adenomyosis or adenomyoma initially as first line treatment. If the patient doesn't conceive or there is a miscarriage, I go for even a smaller size adenomyosis may cause, or adenomyoma may cause the problem. So size as such comes secondary, but it should not be used primarily.
Rather, we can use suppression, sir. Ultra long suppression.
Yes, I always use the ultra long suppression. before putting the embryos, and many patients, they do benefit
They do benefit.
if there is no conception again, or there is miscarriage, then combine it with even after surgery, because you are not removing completely adenomyosis. Even after surgery, there is an element of adenomyosis remaining. So combining suppression as well as surgery gives a better outcome in this case.
Thank you, sir.
It is always difficult while operating the adenomyoma. It is always difficult to get the plane of dissection.
There is no plane actually. There you have to create a plane, and
Yes,
how do you create? So mapping is very important. You must know how much to remove. Always keep at least 0.7 to 1 centimeter on both sides. Otherwise, it will be difficult for suturing, or there will be loss of tissue extensively. You will not be able to re-suture it properly. So always keep that margin when you are doing especially the diffuse adenomyomectomy. When you are doing diffuse, because there is no marker.
yes, sir.
So always map the size, how much you are going to. So you have to do 2 surgeries basically. One surgery before doing a surgery in your mind, that this much I am going to do, how you are going to do, and then do the actual surgery.
So 3 quick queries, sir. One is like, if there's a big fibroid, like broad ligament, stenting should be done or not prior? Stenting, no stenting, ureteric stenting.
Broad ligamentary fibroid, usually they don't cause any problem as far as the fertility is concerned. Only thing, if it is a large fibroid, it will distort the tubo-ovarian relationship, and that is how it causes the infertility. So,
no, for the sake of ureter, you do stenting or you not do no stenting for the large fibroid?
Stenting is usually not. I don't use stenting, but I do identify it before where it is, and keep and you can just expose the ureter before doing the myomectomy, so it is under your vision.
Okay. Second, is the barb suture or Vicryl?
I use the barb suture.
Barbs, no.
Yeah, they are
morcellation.
quite comfortable. They are quite comfortable.
Morcellation for all, sir. The big fibroids. Morcellation karte hain?
Yeah, morcellation.
There is no other options. Okay. Thank you. It was very nice and excellent presentation. We really enjoyed your videos and we missed some also. So any questions from the audience, or should we go for the next lecture? So thanks a lot, sir. Thank you. Thanks for your excellent presentation, sir. Thank you.
Thank you very much.
Thank you, sir.
And thank you and congratulations again for the.
Thank you, sir. Thanks.
Thank you.
Thank you, sir. So for the next, I think who is taking over, Sushma, for the next presentation?
Actually, we are going to have panel discussion for this lecture.
Ma'am, thank you so much, sir, for your pulse of wisdom, along with giving so much of questions after all. We would like to start with role of laparoscopy in endometriosis by Dr. Rekha Ratnani, ma'am. For this session, I would like to invite the chairpersons, Dr. Pragya Suryavanshi. Can I have a CV, please? She has done an MBBS, MD, and FICOG and DRM from Germany. She has been invited as a faculty and speaker in many national and international conferences like IMS, UVA, FOXY, and many paper presentation in national conferences. She has been an ex-consultant at GRMC Gwalior, received Women Recognition Award in 2018, and member of IFS, IMS, and ASHRAE. She has done a best paper and poster presentation for IMS and ISAR, respectively, and she has a special interest in high-risk pregnancy and ART. I would like to invite you, ma'am. I would like to invite Dr. Varsha Jhunjhunwala. She is MBBS, DM, and DGO, and a PG from St. GS Medical College and KM Hospital, Mumbai, and senior residency from Lady Harding Medical College. She has done her advanced training in reproductive endocrinology and ART from Bad Wunder, Germany, and director at Jhunjhunwala IVF Center, Nagpur. I invite both the chairpersons and kindly invite the speaker for our next session.
Thank you, dear, for introducing words. Without wasting much of our time, I think we should start with our next presentation, which is by Dr. Professor Rekha Ratnani. It's my proud privilege to introduce ma'am, who was my co-roommate during my UG days in Pandit JNM Medical College, Raipur.
That's why I chose you, Varsha.
Thank you, Sushma. So, ma'am is presently head of the department at SSIMS Bhilai. She is the head of advanced laparoscopy and IVF unit at High-Tech Super Specialty Hospital Bhilai. She is an ex-professor and HOD at CCM Medical College Durg, ex-associate professor at our own Pandit JNM Medical College Raipur. She is an ex-IVF and endoscopy head at Apollo BSR Hospital, Wokhad Hospital and Baby Shore Hospital at Nagpur. Ma'am has done her MS in general surgery and then she has done her MD in OBGY. She is a fellow in minimal invasive surgery and in ART from Boston. And ma'am has many publications and presentations at both national and international conferences. So over to you, ma'am, for your presentation on role of endoscopy in endometriosis.
Thank you, Varsha. It's like long time.
Yeah.
I haven't seen you or I haven't even heard you. So thank you for such a wonderful introduction.
Thank you.
And thanks to Sushma for
Yes,
actually, doing all this. Actually, I have emailed my slides to, I think, Praveen or someone, and I've asked him to
To me, ma'am. I'm just sharing it soon. Are the slides visible?
Yeah. Then next, I'll be taking a help actually. Can we go to the next slide, please? Yeah, slide share, screen full kar do. Yeah. So I think a short introduction to to endometriosis before proceeding to the actual laparoscopic treatment. We all know that it is a condition where we find this actively functioning endometrial tissue and glands. Apart from the usual site, that is uterus, it can be present at various ectopic sites, which actually leads to a lot of inflammatory changes and fibrosis. Next slide, please. So definitely when patient comes to us, it is a very, very painful condition for them. We have to be at a very high alert to, understand and treat this disease. It is prevalent about 10% in all women between menarche and menopause. But actually, when you see your infertile patients, next slide, they really constitute a big chunk. Around 40% of infertile patients, they turn out to be suffering from endometriosis. Pathology, I will not go into details. We all agree that it is a retrograde menstruation theory, which we all know it's by Sampson. Many a times we do feel that it is really a good theory because we feel that it must be the pathology. But there is also a combination of some failure at the immunological mechanism, which is associated with the stromal cell defect, with its increased estrogen, prostaglandin, and progesterone resistance. So yes, there are many other factors. Next. Coelomic metaplasia theory, the circulation and implantation of ectopic menstrual tissue via venous or lymphatic system or both are also true, because I myself have seen a case of catamenial endometriosis where she would cough out blood during her periods. So, we have to believe that there must be some venous route or some lymphatic route from where this tissue must be traveling and implanting at that site. Next. Hormonal influence. Yes, the initial genesis of endometriosis is further development depends on the presence of hormones, mainly estrogen. Pregnancy causes atrophy, we all know that, because of the high progesterone levels. And regression also happens when you do hypophorectomy or when these patients are irradiated. Endometriosis is rarely seen in a young girl who has not achieved menarche, and also you never see it after menopause. Next. Immunologically, yes, all our recent advances and stud books are, full with this data. where they have come up with a lot of research, and they say that immunological factor plays a major role. And when they collected this peritoneal fluid in these patients, they saw a lot of macrophages and NK cells. And there is also associated impaired T cell and NK cell activity in these patients. Next. Genetic, yes. You many a times find a tendency in about 15% of cases. Next. So this is a slide where I think you can find it everywhere. Look at outside vulva, inside, even near the perineum, anterior surface, in the anterior cul-de-sac, posterior cul-de-sac, inside the myometrium, inside the endometrium, at the vagina, uterosacrals, umbilicus, any scar, any previous scar, everywhere, even ovaries, which are very common. We all know and we daily encounter them. Next. 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 So now it usually presents as three major variants. That is, it might be just the initial stage, or we call it as superficial peritoneal disease, or it can present to us in a very bad state, that is DIE or deep infiltrating endometriosis, where patient is really complaining of dyspareunia, dysmenorrhea. Her life, her quality of life is very, very compromised. And when we put a scope inside, we come across such type of additions. And deep infiltrating endometriosis is mainly diagnosed in a nicer way while putting a scope on it. Then ovarian endometriomas, all of us encounter these every now and then. So these three presentations are very common. Next. Now, see, look at the slide. Early lesions, you have to keep your eyes open. They can appear as simple as these papular lesions or red vesicles at the peritoneal surface, or in the pouch of Douglas, or in the lateral pelvic wall. You shouldn't miss them. When you put your scope inside, don't forget to look for these small. It will not always be the initial stage, will not give you these powder burn spots or gunshot spots. You have to be very open for this red colored, papular and red vesicular lesions, which are basically telling you about the superficial peritoneal lesions. Next. And then over time, these vesicles, due to, continuous, hemorrhage inside and collection, they then change color, and you can come across these, dark red or bluish or black, cystic areas, or maybe black cystic areas which are adherent to that particular site. In this photograph, you can see it present near the tubes or even over the ovaries. Next. Now, scarring is something which tells us that the disease is at a later stage, and it makes it very puckered. Atypical lesions such as non-pigmented areas or yellowish white thick plaques, you can notice them. They are basically nothing but healed lesions. Next. Powder burnt areas, we all see it in the pouch of Douglas, at the uterosacral junction, on the uterosacral ligaments. They are very common in patients in whom you suspect endometriosis. Next. Now coming to chocolate cyst. Chocolate cyst is something which is easily diagnosed on your sonography. So these are the patients who actually come to you with a diagnosis on the plate. That's the I'm suffering from endometriosis. This is the report. I have been diagnosed with a cyst, which is very nicely documented on sonography due to the ground glass appearance of the cyst. So they are very common, but to the naked eye, they show obvious thickening of the tunica albuginea. Vascular red adhesions are well marked, and the inner surface of the cyst wall is vascular, and it contains areas of dark brown tissue. When you try to pull out this cyst, or the cyst wall of the chocolate cyst or endometrioma, you will realize that it is very difficult. It never comes out very easily like a normal simple cyst wall. It is very thick, rubbery, and it is really densely adhered to the ovarian surface, inner surface. Next. So I see that you can initially drain these endometriomas, but it is not going to help. Once the scope is inside, drain the endometriomas and then try to take out the cyst wall in total. Next. Next. Now you have to be very vigilant and keep your eyes open for the history. No patient will tell you openly that I'm suffering from endometriosis until and unless these are chocolate cysts. So deep-seated dyspareunia, severe dysmenorrhea, or at ovulatory time, mid-cycle period, they have pain. So you should have a high alert for these patients. Next. Chronic pelvic pain. Don't ignore these females who come to you with this chronic back pain, loin pain, or painful defecation or painful micturition. Even painful micturition, nowadays when patients come to you, every time they say, I'm having painful, I'm not comfortable. You feel it is UTI. But believe me, they do have, when you put the scope inside, you will, really, really surprised to see that they are basically suffering from endometriosis, which is not being diagnosed easily on the sonography. Next. Infertility, yes, most of the infertile patients, when investigated, they do turn out to be endometriotic. Unexplained fatigue, or may not be, there may not be vaginal bleeding. Rarely, as I told you, there can be hemoptysis or cyclical hematuria. Next. Risk factors, first degrees, we all are prone if our mother or our sister is, suffering from it. Patients who have short menstrual cycles or frequent cycles, and they have more prolonged duration of the flow, low parity, fair complexion patients are definitely at high risk. Next. Diagnosis on bimanual pelvic examination, if it is having additions, you can catch this retroverted uterus with pelvic tenderness, enlarged ovaries, or maybe some nodularity. Deep infiltrating nodules are very reliably detected when you do their clinical examination. During menstruation, don't forget to do their examination during menstruation. Even when you want to take them for surgery, call them during menstruation and try to do their PV examination, because that is the time when her nodules, when her lesions are actually prominent and they are very easy to diagnose. Adenomyotic uterus is seldom more than 12 weeks. It is soft, smooth, tender in contrast to a fibroid uterus. Isolated adenomyoma can be differentiated by localized tenderness. Next. Next. So painful adnexal masses, painful nodules in pouch of Douglas. These nodules, they are basically best palpated and appreciated during menses, as I clearly told you. Next. Sonography, I told you endometriotic cysts are very nicely diagnosed on Doppler. No vascularity is seen in these masses. You can see the adhesion. You can even see them stuck to the posterior wall of uterus. And you can also see free floating fimbrias on sonosalpingographies. Next. This is how the ground glass appearance of endometrioma is there. And you can immediately see the report and diagnose them. Next. Next. MRI is very good when you are expecting or suspecting DIs. When you feel that there can be deeply invasive component to the bowel or to the bladder, then definitely MRI is good. Colonoscopy, cystoscopy, rectal sonography, and contrast enhanced MRI. Rather than plain MRI, go for contrast MRI, and you might need rest of the investigations also. Next. Laparoscopy is definitely gold standard, not only for diagnosis, but also for therapeutic confirmatory treatment. It should not be performed within 3 months of hormonal treatment to prevent underdiagnosis. So as I told you, don't do it when the patient is on hormones or she has already taken eupride or something. Let her menstruate, then only try to palpate it and then take her for laparoscopy. Next. So these are the lesions which you shouldn't miss. The angry look of the peritoneum you should not miss. Next. Cysts, very clearly you can see how it is deeply stuck. Next. Cluster, you can see these clusters of small chocolate cysts even in the, just laterally in the lateral pelvic wall, which can later on increase. Next. Raspberry spot endometriosis, very small red spots, but you have to catch them and ablate them. Next. Then these dense adhesions, no one is going to miss it. Next. 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 Confirmation is very important. Whenever you take the patient for laparoscopy, try to take out the tissue. Don't diagnose it, but also take out the tissue so that you can send it for confirmatory report also. And in cases of ovarian endometriomas, when the size is more than 3 centimeters in diameter and in deeply infiltrating disease, histology is very important to rule out malignancy. Next. I will not go into the details of AFS grading, but there is one thing which I would like to highlight. That is, whenever the pouch of Douglas is it's completely obliterated. We call it like completely obliteration. You give directly 40 marks. You label it that it is a stage 3 or stage 4 endometriosis. So this is one thing which I feel we all should mention and note also. Next. Next. So in short, I would say if the score is more than 40, it is stage 4. And if it is within 5, score is within 5, then it is minimal disease. Next. Now treatment, you can treat it medically, surgically, you can combine both. Medical management can be for pain control or prevention of menstruation. But if you want to treat her properly, then definitely laparoscopic management stands true to its words. Next. Now, indication for surgical management, first of all, you want to diagnose it. Many times the patient will come to you with acute pain, or she's coming to you repeatedly with chronic pain. You have to take this patient and label her, confirm her diagnosis so that you can treat her and put her on medication. If it is significantly implicating or impacting her quality of life, then you have to take her for laparoscopic. Then you have given medical management, but something is not working for her. Take her for surgical management. Infertility, you want to investigate and treat, you have to take her for laparoscopic management. Endometriomas, yes, you have to take them. I'll tell you what are the conditions when you shouldn't take them. And if there is other secondary organ involvement. Next. Surgical management, if you ask me, if you want to take this in a patient who has completed her family, then definitive surgery, that means total abdominal hysterectomy with bilateral self-hemoptyectomy, excision of peritoneal surface lesions or endometriomas and adhesivolysis will completely help. But if you are trying to do semi-definitive procedure where you are preserving an uninvolved ovary, you are increasing the chance of recurrence by 6 times and you are increasing the chance 8 times for reoperation surgery. Next. Surgery pros and cons, we all know that it is very good for diagnosis, treatment, and it has got really good result on, for fecundity improvement. Disadvantage, yes, you need to be really trained in doing endometriotic surgeries in endometriosis patients because risk of injury to organs is always there. There is a lot of addition. If sources are limited, you will be in trouble. You really need a lot of experience. And there can be chances where you feel it is endometriosis, but it turns out to be negative. Next. So what are the difficulties which we will face while operating an endometriotic patients? It can be a focal disease or it can be a diffuse disease. Now, localization of the disease, it can be just ovaries, it can be, pouch of Douglas, it can be your bowel, sigmoid, or everything is adhered and you are just not able to find a window where to go and from where to go. Then extension of the disease, you all will agree, you all must be operating it. The extension, many times it is up to, it starts from ovary and it is going to the whole pelvis, or the adhesions are so dense and so firm that, it is almost like curtain. They're so hard and so severe and there is no clear cut, delineation between the bowels also. And you are in trouble if the same patient has got myomas also or PCODs also. So you really need to have good experience, but I'm thankful that laparoscopy gives you good magnification and you can really help the patient. Next. So dissection, if you are taking the patient and you want to dissect these adhesions, you want to do dissection, then again, if it is an infertile patient, you need to know what you are using. What is the source? Are you using dissecting forceps or you're using cold scissors? Are you going to excise the lesion? Are you going to do it with scissors, cold scissors, or you want to use current? If you want to use current, are you going to use bipolars, monopolar, or you want to use harmonics? What you want to do, because you cannot compromise the ovarian reserve. If she suddenly starts bleeding again, to go for monopolar, you want to go for sutures, it is always better to go for bipolar or harmonic cautery in patients who are keen for conception. Now, many times there is lot of conflict that people who are very good at laparoscopy would always say that laparoscopy is good. Who are not good in laparoscopy, they will always say laparotomy is good. But if we are very honest, both have their pros and cons. Laparotomy, it will give you less operation time but longer hospital stay. But I would say laparoscopy is really good in patients who have stuck uterus, where the uterus is stuck in pouch of Douglas, where ovaries are stuck. Mind you, I have tried it many a times by open surgery. It is really difficult to go posteriorly to the uterus and clear everything. But when you are going through laparoscope superiorly, things are much easier. You are mainly very careful. You can get the planes. So laparoscopy gives you better magnification with 30-degree angle scope. It is really nicely visualized. Hospital stay is definitely less. Probably less damage to the healthy tissue because it is magnified. Due to handling, there are better results, less post-op pain. Although there can be a little risk of complications, if there are more additions, there can be blind entry. And talking of laparotomy, yes, better ergonomy is there, more pain is there, but more vulnerable to normal tissue due to bigger instruments. So you might not get that finish when you are using laparotomy instruments because it becomes little blunt, crude, where you are handling it directly. Next. So if you want to go for endometriomas, where you want to drain them, you want to pull out the cyst wall, they should be more than 3 centimeter. That is ideal. Go for adiolysis first. Don't try to drain the endometrioma directly. Try to separate the ovary if it is stuck, if the ovary and tubes are stuck. First, maintain the anatomy, clear the anatomy, do adiolysis. Then drain the chocolate cyst, vaporize all the peritoneal lesions, whichever you can see. Now you do cystectomy and then pull it out. You can also put these patients, you should put this patient on medical therapy. And if you want, you can take them for second look laparoscopy, but again, it is a debatable topic. Next. Now, laparoscopic ovarian cystectomy will confirm the diagnosis, will rule out malignancy. It will reduce the chances of recurrence if you do the cystectomy. And if you are just fulgurating it and not removing the cyst wall, then definitely she's going to come back to you. It will also reduce the risk of infection during IVF. It will improve the access to follicles and probably improve the ovarian response, but it may impair the ovarian reserve if you're not careful with the electric currents. Next. Excision is better or ablation. Again, excision may you have to be careful what you are using. If you are using just, minimal currents, bipolar or harmonic, and seizures, it is very safe. And if you're ablating, then use bipolars. Next. Now, excisional surgery versus ablative surgery for ovarian endometrioma, there is a Cochrane review which says that there is some evidence that excision is better, more favorable than drainage and ablation with regard to the recurrence of endometrioma, recurrence of symptoms, or subsequent spontaneous pregnancy. Next. So as you can see, risk of recurrence of ovarian endometriomas after 1 year in patients who have undergone excision is less compared to coagulation, which is nearly 3 times. Next. Now again, there is a lot of debate going that ovarian response is compromised after surgery. So there is this study, and they have tried to find out that what happens to the IVF ET outcome after endometrioma removal. So they say that there is no decrease in the IVF ET outcome if the cystectomy is done, and these are on the left side, they are in the favor. And I got only 2 studies which were not in favor, and they said that yes, it decreases the ovarian response. Next. Now, role of laparoscopic surgery in endometriosis and infertility review. There are a lot of studies which say that it is good evidence. There is good evidence that endometriomas more than 3 centimeters should be excised, but there is no RCT that specifically addresses if laparoscopic surgery in moderate or severe endometriosis will improve pregnancy rates. Next. Now, if patient comes to you, endometriotic patient for the pain, then definitely you can use laparoscopic. Next, you can go for laparoscopic uterosacral nerve ablation, which is very easy. You have to just open the posterior leaf of broad ligament, identify the course of ureter. We definitely would usually do while Vardimes, and even in laparoscopic modified radical hysterectomies, we do that. Or even in laparoscopic hysterectomies, most of the time we open the posterior leaf of broad ligament and you secure the ureter. So just try to open the posterior leaf of broad ligament, track the course of ureter, identify it, and safely keep it in a safe zone. Take care that you are not puncturing the small pelvic vessels which are lying lateral to the uterosacral ligament. Now just you have to ablate this uterosacral ligament using 5 mm bipolar cautery, which is you connected with the Maryland. Adjust your current at 30. Apply the energy for 5 seconds in order to deliver just 150 joule coagulation current to each ligament. Now start this ablation as close as possible to the posterior aspect of the cervix and continue for minimum of 1 centimeter on both the sides. So just for 5 seconds on one side, again 5 centimeter, and you cover area of around 1 centimeter. Next. So does surgery help in pain? Yes. Luna, there are studies which say that relief is around 63%. Next. There are Cochrane reviews which say that yes, laparoscopic surgery reduces pelvic pain which is caused by endometriosis, and it should be done for pain relief. Next. Now DIE, very difficult. As a surgeon, as a laparoscopic surgeon, I would really tell you that it is difficult and you have to be very clear with the anatomy, but you should be prepared for everything. Nowadays, gynecologists, laparoscopic gynecologists are doing all these surgeries. They are repairing the rectums and all the complications are handled very well. So deep infiltrating endometriosis may be responsible for failed surgical treatment. There must have been error in diagnosing during your first laparoscopy, or maybe you must not have realized that the patient is suffering from that severe disease with her symptoms. And when you put your scope, you find out that she has got deep infiltrating disease. She may come to you with deep dyspareunia, or when you do rectovaginal examination, you can feel those nodules, you can feel that fixity, and rectal ultrasound and contrast enhanced MRI will definitely tell you that there is loss of plane between the rectum and uterus. Next. So these are the various pictures where you can see that these patches or the adhesions or the deep infiltrating nodules which are to be excised in toto. Totally you have to excise them, then only the patient will get relief. Next. Now, do you want to go for conservative surgery? Yes, you can go for conservative surgery. Try for a complete resection. Try for complete resection, and mandatory preparation would be that do assessment before surgery. Try to aim what you are going to do, and if the aim is excision of nodule, then if you just want to excise a nodule, use shaving technique where you just resect out the nodule. Don't do anything to the bowel. If there is uterosacral ligament infiltration, you have to take those nodules. Vaginal infiltration is there, you have to take those nodules. Bowel, if it cannot be spared, then you have to do bowel resection. Otherwise, discoid or segmental bowel resections are sufficient. And then you can go directly laparoscopy, and many times if you're not comfortable or pain is not there, you can go for assisted techniques. Next. Recurrence rate, yes. Recurrence rate in DI is there, around 27% recurrence rate is there, or the operation rates are there. Next. Post-operative results are defined according to the quality of life, fertility degree of treatment, pain recurrence, or complications. Next. Now, what additional skill you should have if you are going to do these cases? That is, if you are going to attempt advanced endometriotic surgery. You should know ureterolysis, or identifying the ureter, separating the ureter. You should know how to remove appendix. Many times, most of the studies, they support that we should remove and do appendicectomy along with endometriotic surgery. Bowel lesions, if they are there, you should know how to repair the bowel, how to take care of the injury, or if you need to go for, like discoid lesions or something, you should know how to repair it. Cystoscopy, I would advise every surgery of endometriosis, you should do a cystoscopy before shifting her out of the OT. Rigid sigmoidoscopy, it is very, very helpful. Mind it, many a times very small perforations will not be caught, or small injuries or current injuries will not be identified. But the moment you put a sigmoidoscope and you try to put some pressure through it and put saline in there, you can see nice bubbles. Next. See, if the appendix is found like this, the hockey stick sign as we call it, you have to remove it. Next. Risk factor, there are a lot of risk factors when you are attempting advanced endometriotic surgery. Severe endometriosis is the main contributing factor for bowel injury in patients with no previous surgery. So remember, you have to be prepared for encountering this complication in deep infiltrating endometriosis. Next. Now, how it will happen? Many times it can just happen by manipulating it with your instrument and it is gone. It will just open up. Or when you're trying to do some adhesive or you're trying to separate the bowel adhesions which are, adhered to each other. Many times you want to just, apply some hemostasis, you want to attempt some hemostasis and you're using some bipolar current, it is there. But if you're definitely using monopolar, the chances of injury are very high. Next. Urinary tract complications are very common with these surgeries. Ureteric injuries, bladder injuries, fistula formations are really high. Bladder injuries are identified more, around 87% most of the time during surgery. So they're identified more, and ureteric injuries are something which will come to you after 2 or 3 weeks. So rate increases with the difficulty of technique. And pelvic endometriosis causes around 65%, increases the risk of ureteric injury. Next. So these are the sites, I think all of you know where it is vulnerable. So I told you, just open the posterior leaf of broad ligament, identify your ureter and keep it at laterally, and then you can attempt your surgery. Next. Atraumatic, when you're doing dissections, there are some rules. Don't do brutal manipulation. Be very gentle. Don't pull any bowel or anything. Do not pull or do not push the ureter. Just do not grasp your ureter with your forceps. You can use atraumatic forceps, and you should have control of forces. You should be very, very gentle with your hand movement. Next. How will you prevent it? Ureter should be localized. I told you, just keep it under your vision and open it, keep it under your vision. That is best. Many studies are there where they say that, pre-op catheterization or stenting or, stents with lights and all, they are very, very good. But let me tell you, it becomes very difficult. It becomes very rigid. So it is not a good idea always. So systematic placement is abundant nowadays because it does not prevent all lesions and it has its own morbidity. At the end of the surgery, I would say see or look for ureter peristalsis and absence of dilatation. Again and again, I'll tell you, just see that your ureter is separated before your surgery and keep your ureter under your vision. And after surgery, not only the peristalsis, but also a cystoscopy is a must. Next. So how you will identify this ureteric injuries? They will come to you with pain, mainly flank pain, fever, especially after a week or maybe 3 days. After 24 hours or 48 hours, endometriotic patients will complain of pain. That is normal. Mind it, because of so much of handling and manipulation, patients do have pain. But this is something different. They have this flank pain, and within 3-4 days, after 4 days, the pain increases, fever increases, vomitings increase, and there is distension many a times. So do not be scared of, advising these contrast CE urograms, and which are very good in identifying these lesions. Next. So even for bladder, I would say, if you are just doing adhesive, you can harm the bladder during laparoscopic surgery or when you're trying to remove these implants. But as our seniors and Shailesh sir tells us that, bladder is very forgiving. So even if you see it, just repair it under vision in that setting. Next. So it is 3% in advanced laparoscopic cases, laparoscopic endometriotic surgeries. And it is because of or electric trauma, electrothermal trauma. You can prevent it by a catheterized bladder. See that you put your secondary trocars under vision, and blunt dissection is always better than electrocautery. Next. Now, coming to symptoms, how will you identify a bladder injury? Very common. I have encountered it. So it is just your urobag, which would just swollen up immediately. Not only hematuria will take time, maybe little time, but swollen urobag will be just so obvious. So if you're suspecting it, just look for a swollen urobag, hematuria, presence of urine, it is very good. Or if there is no urine after surgery. Next. So risk reduction, general guidance, I would say put Foley's before surgery, prepare bowel well, avoid nitrous oxide, tell your anesthetist not to use it because it causes distension of the cut. Use nasogastric tube or Ryle's tube before surgery. Lysis of adhesions between the bowel and anterior or lateral abdominal wall should be done initially. Lies the adhesiolysis of sigmoid has to be very careful. Continuously you observe your operating field everywhere, whether you are keeping your intestine safe or not, your bladder and ureter safe or not. So reduce risk of port-site metastasis can be done by closing in layers, and the risk of vaginal spread by avoiding uterine manipulation. So if possible, do not use much of uterine manipulation. If we are not removing the uterus or anything, don't try your assistant or anyone to use anything from the vagina. Next. Check instrument insulation properly before using them. Use lowest possible power and current. Use low voltage waveforms. Interrupted currents are advisable and not continuous activation for long time. Do not activate when it is an open circuit, and do not activate when the diathermy touches another instrument. Be very careful. See that you follow this algorithm. Next. Use bipolar whenever indicated. Use iron or plastic tocars, but don't use them mixed, half iron and half plastic. Be very careful, very clear what you want to use. New technology, electrogenerators that control electric currents and protect from capacitative currents. Nowadays, these new bipolar shearers have come, which have minimum or no transmission of currents. So go for those latest instruments and electrical arrangements. Use of equipments with active electrodes. Use those equipments that protect from insulation problems and from capacitative currents. Next. Recurrence in endometriosis is very common. It is at 5 years after initial conservative surgery is 13.5 to 40%. So ACOG practice bulletin in 2010 says the most common site of recurrence are large and small bowel after hysterectomy. So see that, bilateral salpingo-oophorectomy is also done along with it, and keep your patient under observation. Next. Cause of recurrence, I told you, when you have misdiagnosed or have not given enough thought that this patient might be having DIE, and you must have left the lesions behind and not put her on suppressive medical therapy after your surgery. Next. So atypical, even small white lesions, atypical non-pigmented lesions which you fail to diagnose can also be a cause of recurrence, where they have now gone a step or stage higher and come to you with same symptoms again. Next. So many a times when the peritoneal adhesions are there in pouch of Douglas, you're not able to clean those adhesions. You're not able to separate your bowel from the pouch of Douglas, and the lesions are there itself hidden, and you don't know what is the stage. As I told you, whenever the pouch of Douglas is completely obliterated, it is stage 4. Treat it at stage 4. If you cannot handle it, just stop your surgery. Either send that patient to someone who is very good at stage 4 endometriotic surgery, or immediately put that patient on medical therapy. Next. Ovarian remnant syndrome. Recurrent endometriosis has been associated with presence of residual tissue. When you leave some ovarian tissue behind, or some amount of cyst fall behind, then these can come to you with recurrent syndromes. Recurrent endometriomas or endometriotic disease. Next. So try to go for adhesion prevention, do pre-sacral neurectomy if pain is really too high, and try to do appendectomy, and up to 20% diseases, because we have to do it, otherwise it will come to you with pain or infection in the later stage and you will have to reopen it. Next. So conclusion is primary operation is the best opportunity. You will get the best outcome by excising of the lesion rather than ablating. Complete excision has lowest recurrence of 19%, which is again not very low. Additions will require excision rather than simple division. Next. Most of the complications during laparoscopic surgery for mild and moderate endometriosis can be avoided by gaining knowledge, by improving surgical skills, by increasing your experience, by operating more in number and severity cases, and it depends on severity of cases of endometriosis. Next. Severe form of endometriosis and DIE demand complex surgery, and radical approach is mandatory in order to achieve better quality of life. Scrutinized preoperative workup is mandatory. Sometimes complications cannot be avoided, so you should have a nice consent form which mentions everything, where you have to tell them that she might require, discoid segment resections or bowel resections or bladder injuries or catheters for long time or stenting or ureteric implantation. So you should have these detailed counselings, and counseling forms should be signed before the surgery. Benefit versus risk must be evaluated in detail, weighed and judged appropriately, and discussed with the patient prior to surgery. Next. So thank you so much for your kind and patient hearing. Any questions?
Okay, ma'am, you're not audible.
Hello?
Hello.
Yeah.
Well, you have given a wonderful lecture, ma'am. But in borderline cases, having endometriosis of about 4 to 5 centimeters, just elongated cyst, and when we are taking the patient for IVF, in such patient there is dilemma ki whether we should how we should treat the patient, whether surgically or medically, because even after giving treatment for around 3 months, there is no decrease in the size of endometrium in some of the patients.
I would always suggest go for surgery, because when you want to take them for OPU also, removing these cyst walls, there is enough space for these follicles, because whatever medical treatment you give them, those cysts are not going to go anywhere.
They are not going anywhere, ma'am, and there is no reduction in size.
Size also. But yes, there is the history guidelines nowadays. They say that if it is unilateral, you have to operate. If there is previous history of surgery, avoid it, because you are going to play with the ovarian reserve of that patient. But if it is unilateral, go for it. If it is bilateral, avoid it. Just go for single, because you can reduce her ovarian reserve. Yeah. And they say that if you feel that there is folliculogenesis while you are doing OPU, you can, you can do your OPU. Later on, you can drain it in the same sitting, or you can avoid it. But try to give good antibiotic prior to your OPU and after OPU also. Injectable OPU, injectable antibiotics 3 doses, and then you can keep her for say 5 days. Because they said that whatever studies they have done, they have not found increased incidence of pelvic abscesses or ovarian abscesses in such patients. So nowadays they are talking of don't do. But to be very practical, Dr. Sushma, I feel, what is the point in giving them, these medications where you are delaying their pregnancy for so many months? No point.
Which causes delay in the pregnancy.
Yeah, so best is put a scope. If it is more than 3 centimeters, there is no space. If it is stuck, just clean it. At least you know what, you map that patient, before taking her for IVF. You have seen inside, what you're going to get. Once you go inside, many times you are shocked to see that what was reported in your sonography was too less. Yes. And what you are saying,
many times it happens in cases of endometriosis.
Yeah, it is too much. And also till date, I have encountered 2 patients who turned out to be malignant. Two patients. And the moment, and it was not diagnosed on sonography or MRI. We took her as endometrioma, infertile patient. The moment we put scope, we could see, the moment I started draining it, I could see those, papillary projections. And we had to, block it so that there's no spillage. She turned out to be, because endometrioid carcinoma is very common in these patients, their outcome is very good. So she was then referred to Bilaspur. But how can you take these patients without laparoscope for long periods? I have seen people debating that we should not do laparoscope, we should not do. I think put laparoscope and you will feel more convinced that you should put more laparoscope. I'm not saying that we should ablate and we should use and we should injure, but at least put a scope.
At least we can see the spread of the disease in the pelvis.
Yeah, actually, that's it. And if it is really, really bad, everything is stuck, then it gives you a chance to, do, if you want to do delinking or, whatever you want to do, if the age is more like she's 38, 39, you want to go for IVF, there is no ovarian reserve, but she's coming to you with pain, or that you have done her, she has got her IVF done in some different center. Why will you attempt a second IVF without delinking in such a huge patient with such big disease? So I still would suggest laparoscopic surgeries are wonderful in endometriosis patients.
Thank you very much.
Many a times, I just have a small question. Many a times we see these endometriotic spots. You also mentioned in your thing. So if they are coming and their only symptom is pain, this is not related to infertility. They are having lot of pain. So should we fulgurate it or remove that those spots or those cysts?
Yeah, that is what the study says, that if you ablate it, it is not going to help. So, just hold it and, with the cautery, you have to cut those lesions, excise those lesions. They might appear small, but you have to excise all those lesions, and then only the recurrence rate is less and pain relief is also. That is what the study says. They followed up these cases and they said, no, initially they were talking of ablation. We all have learned ablation. But now the latest data says that excision would give you better pain relief and also less recurrence.
So suppose we are doing a laparoscopy for an infertile patient also, other than these spots where she can be put into stage 1. So there also it is recommended that we should remove these small spots.
Yeah. In IVF in infertile patients, if she has come to you, you are just doing a simple diagnostic. Just simple diagnostic also, you have to remove these lesions. Long back when I was with Dr. Sanjay Patel sir in Mayfair, so he would say that our IVF results are very good because we catch hold of each and every lesion of infertile patient. Small, they would spend a lot of time and they would excise each lesion or ablate and all. That time I was too young, I was not knowing anything. But now the studies do say what these stalwarts were actually practicing that time. Any more questions, or we should just find it up?
We are running short of time, ma'am. We have to move forward for the panel discussion.
Yeah, thank you so much.
Thank you very much, ma'am, for the
nice presentation. Thank
nice
you.
presentation.
That was really good, ma'am.
Thank you so much.
Moving forward, actually, Dr. Ishpreet ma'am had an emergency. She texted me. I'll proceed. Let me share my screen first. So moving for panel discussion on hysteroscopic surgery, a perfect evolution. The moderator for this session will be Dr. Veronica Joel, Dr. Mansi Jain. The panelists, let me introduce Dr. Veronica Joel. Dr. Veronica Joel, Secretary of Chhattisgarh Chapter of Indian Fertility Society 2020-2022, Joint Secretary, Chhattisgarh Chapter of Indian Fertility Society 2018 to 2020, Treasurer 2013 to 2018, Assistant Secretary of Chhattisgarh Chapter ISAR 2010 to 2020, published many original papers and books, chapters in reputed indexed national and international journals in the field of assisted reproduction, obs and gynec as first author. She has tremendous potential and tremendous many more awards under her name. Dr. Manchi, Diploma Clinical Art, Fellowship in Reproduction Medicine and Surgery, Singapore, Consultant Reproductive Medicine, Tiny Endoscopy Surgeon at IFS and Laparoscopy Center, Delhi, Indrapuram and Faridabad. Co-convener SIG Endoscopy IFS 2022-2024, Fellowship in Reproduction Medicine through Thomson Fertility Center, Singapore. She also has a lot of awards, many more under her name. The panelists for this session will be Dr. Ritu Jain, Dr. Shilpa Pawar, Dr. Munmun Agrawal, Dr. Priya Mishra, Dr. Sudha Agrawal, Dr. Kishan Chanania, Dr. Paulami De, Dr. Priya, Dr. Ritu Jain, Secretary Raipur Menopause Society 2022-2024, Executive Member Raipur Menopause Society since 2014, Organizing Committee Member AOGCG Annual State Conference from 2010 till 2021, NZYF 2011, Zonal IMF Conference 2014, 4th FOMs and 22nd National IMS Conference 2017. Annual State MenopauseCon 2018-2019.
Piyush, let me introduce the panelists.
Yes, ma'am, sure.
Please move forward the slides. Welcome, Dr. Ritu, for the panel discussion.
Thank you, ma'am.
Now let me introduce Dr. Munmun Agrawal. She is a practicing obstetrician and gynecologist since 8 years, and she is a specialist in high-risk pregnancy and infertility, and she is the director of Sri Dhanvantari IVF Center, Raipur, and she is the receiver of Best Paper Award, National IMS, and received Health Pride Award from CM of Chhattisgarh. Welcome, Dr. Munmun. Are you there, Dr. Munmun?
Yes, ma'am, I'm there.
Yes.
Thank
Dr.
you, ma'am.
Priya Mishra, she is the director of Sri Siddhivinayak Test Tube Baby Center, Bilaspur, and she is practicing gynecologist since last 10 years. Dr. Sudha Agrawal and Dr. Shilpa Pawar, she is an obstetrician and gynecologist and fellow of reproductive medicine, consultant gynecologist and IVF specialist, and director of Santati Fertility Center, ex-lecturer of Indira Gandhi Government Medical College, ex-assistant professor MGM Medical College, executive member of ROX, and winner of UA ISAR 2017 award at Ahmedabad. Welcome, Dr. Shilpa. And now we should start the panel discussion because we are already running short of time.
Can I share my screen? Piyush, can I share my screen?
Yes, ma'am, please try.
Do you have the CV of Dr. Paulami?
Apologies, ma'am, I don't have.
Dr. Paulami is one of the panelists participating in the today's panel, and she is the obstetrician and gynecologist, infertility specialist, and ex-consultant genome IVF Center, Raipur, and presently working at Raipur as a IVF specialist.
Shall we start, Mansi?
Okay.
Okay. Thank you all for the very kind introduction. Now, as we are very short of time, I would straight away would want to move on to some of the questions that we have put. We would be very short, not discussing actual cases, but actual scenarios that we usually face, clinical problems that we usually face in our day-to-day practice of infertility. I have tried to keep it much more closer to handling scenarios which we face in our day-to-day practice. So now we know that science has evolved, and so has the science of hysto and laparoscopy. Infertility is constantly rising, so much so that uterine pathology is contributing to a significant portion in such cases, and therefore evaluation has to be done for all the uterine pathologies. Science has evolved not only in hysto and laparoscopy, but to 3D ultrasounds, which are actually aiding into our practice. So hysteroscopy is used in our current infertility practice, both for diagnostic as well as therapeutic purposes. So there are many situations, and here we would stick mainly to the uterine pathologies that are being used. I think, Mansi, would you like to ask the next questions, because all these questions you have actually prepared well and given a talk on routine use of hysteroscopy. How would others like to get? Let's have their views on this.
Sure, my pleasure, ma'am. I once again welcome all the panelists for today's discussion. So let's start with the basics first. I would like to ask a very basic question to all my panelists, and I would really like everybody's take on this one. So in your practice, how do you routinely evaluate the endometrium? We can start with Ritu, ma'am.
Endometrium, first, there's choice of investigation will be EVS, USG. If there is any doubt or a pathology like polyp or submucous fibroid or adhesions, if there is history which is suggesting all these things or findings on USG, then we go ahead with hysteroscopy.
Okay. Anybody else would like to add on something to that? Dr. Shilpa, would you like to take that?
I think Shilpa is not there.
She's not there. Anybody else would like to add on anything to this, Dr.
Follow me?
Yeah, I think 3D USG is a better technique compared to a 2D one. And most of the times, because hysteroscopy usually is not readily available in the peripheral centers, and many of the patients do not have access. So first we can evaluate through a 3D USG. And if we find some cavity abnormalities, then we can go for a hysteroscopy. Regarding pre-IVF hysteroscopy, I feel it is always better to do a pre-IVF hysteroscopy, because many times we may miss on some small polyps at the corneal ends and all in USG, which we may find out in hysteroscopy and do the correction as well.
So what is your practice, ma'am? Do you do routinely hysteroscopy before every IVF cycle?
No, if we feel there is a uterine pathology, not every IVF cycle, but most of the IVF cycles, yes. But first timers, I give a choice to the patient. And moreover, if there are, I see the duration of infertility as well, because many a times when it is a prolonged infertility and we see some kind of PID and tubal block, we should do a hysteroscopy and rule out genital tuberculosis as well. And pre-IVF hysteroscopy also helps because during hysteroscopy we scratch the endometrium, and it also helps in implantation of the embryo. So I think one cycle prior is a good option to do.
Okay. Does anybody else have any difference of opinion? Because like I said earlier, it's a very controversial topic. So I would like everybody to comment on this.
Munmun, unmute yourself.
Is Munmun there?
Unmute yourself, Munmun.
Sorry, ma'am. Yeah, ma'am. I would like to differ. I would not recommend with pre-IVF in all cases. And scratching has a very controversial role. It is not completely proven that scratching does improve the implantation. Pre-IVF, yes, in recurrent implantation failures, if there is a history, and yes, on ultrasound we find polyps, or we can see there is the difficulty in endometrial preparations. We have been trying since 2-3 months, but the lining is not being formed. So these are the cases where pre-IVF hysteroscopy is ideally suggested, in my opinion.
Okay. Another point I would actually like to mention here, when we talk about endometrial assessment, it's not one modality that should be stressed upon. I mean, you get better results when you take a host of all available modalities, like something as simple as a simple HSD at times can give you a lot of information. So my point here was that everything used in combination, if you already have an HSD film, it does give you a lot of information. Yes, of course, a good meticulous baseline 2D TVS scan you cannot do without it. And if you have 3D, then that is definitely icing on the cake. But I would like your opinion on the fact that what is the role of hysteroscopy with the popularization of 3D ultrasounds? Do you think hysteroscopy is still superior?
Yeah.
I think I'll just add a bit to it. Is just before jumping onto a 3D ultrasound, a baseline, all of us, many of us are also,
Yes.
so we'll have to give clear message for those who are practicing some basic infertility as well. So initially a good 2D ultrasound on the initial days of periods, that is the very quiescent phase where many things, many pathologies actually get picked up. So a baseline scan on day 2 and day 3, and if any abnormality is there, like polyps can easily be picked up on a day 2 or a day 3 scan, right? Certain polyps and all. So then it can be aided on by a 3D ultrasound and a power Doppler later, and then we can, decide which case to be actually selected for hysteroscopy.
Yeah,
yes,
definitely.
But I just wanted the opinion that do you still think hysteroscopy is superior to TVS with the advent, keeping solely 3D in mind? So I would just like everybody's opinion on that.
Yes, of course, because hysteroscopy is considered a gold standard for cavity abnormalities, and USG is just a screening method. So of course, it will be always superior, but we have to select the cases particularly which are for hysteroscopy, because not every person we can, for every patient we cannot do a hysteroscopy, and not every patient agrees to go for anesthesia and followed by a procedure. So for screening of the procedures, definitely USG is there, and hysteroscopy always remains the gold standard for cavity problems.
Yes, I think very well put, and it definitely gives you the advantage of correcting, because once you put a scope inside and you see something, then you must correct it. Don't leave it for the next sitting. You have to correct it at the same sitting.
It's the gold standard and direct visualization, so it's always better.
Yes, exactly.
Better. So the evidence also somewhat comes to that. That position of routine use of hysteroscopy in the management of infertile couple is debatable.
Yes.
NICE guidelines also says the same thing, that there is no consensus on the effectiveness of hysteroscopy in treating infertile couples. However, in cases like implantation failures, which all our panelists would like to agree, this is the ESHRE consensus, that if there are indications, definitely it has improved clinical pregnancy and live birth rates. Right?
Yeah.
So
also, anybody doing office hysteroscopy routinely, what is your experience if you're doing office hysteroscopy? How popular is that? Would anybody like to take that, Dr. Munmun?
Office hysteroscopy, no doubt, is a very good advancement, and we should, frankly speaking, I'm not doing an office hysteroscopy, yes, but I would definitely would like to take this up in my practice in near future. And I have seen some gynecologists doing it. It's definitely a very good technique with just a simple 2.9 scope going in, and
yeah, it's helpful for prompt diagnosis if you have this, if you have the scope.
What I have experienced is previously where I was working, we were using that office hysteroscopy where there is a bulk of patients and number of patients are more. You can go for office hysteroscopy, but there are few problems also which you face during it. One is the cooperation of the patient, because usually we don't do it under anesthesia. We just give a cervical block, and there is always a chance of vasovagal, and then the visualization is slightly lesser compared to when you do a proper hysteroscopy under G.
Yes, I think, yeah, very, very nicely put. So I think the message here is very nice and clear for evaluation of endometrial cavity. TVS 2D still is the basic first line investigation of choice. Hysteroscopy remains to be the gold standard because of the obvious advantages we've already discussed, and always better to use everything in combination whenever something is indicated. Like you can even use SIS, not necessarily that you have a 3D machine, not everybody has a 3D machine. So yeah, use everything in combination, and hysteroscopy reserved for selective cases rather than do it in all cases pre-ART. So that's a very important message that we have put out here.
Mansi, your centers, your experience I have displayed. So that gives a clear-cut message. Like, you know, these two modalities should be complementary to each other.
Complementary to each other. And another thing I would like to share with everybody here, that like I shared in my lecture, we have started over the last 3 years, we started doing 3D routinely for all cases. So almost 60% of the times for grayscale 2D, our findings are in agreement. With 3D, we have been able to increase it by 80%. However, often we have seen in almost 10 to 15% of the cases that this has led to overdiagnosis. So this is probably because of the artifacts and, you know, position of the uterus at times, like those bulky retroverted uteruses you have in adenomyosis. So again, the bottom line is that everything should be used complementary to each other. You cannot do away, like Veronica ma'am said, you cannot do away with your basic 2D ultrasound.
Now, this is another clinical entity that we come across very often. Very often, patients come to us with HSG with a report that there is a tubal block. So does hysteroscopy, plain alone hysteroscopy, is it helpful? How will it be helpful? And what does the evidence say? Anybody can take it.
I feel whenever we are doing a hysteroscopy for a tubal block, it should be combined with a laparoscopic guidance, because so that we do not overdo the things. And it's not like all the tubal blocks get treated with tubal cannulation. If we see in HSG, there is a tubal block around.
So there is a particular indication where just hysteroscopy alone will help.
In a corneal block, we can.
Yes,
it's a corneal block where we can use a hysteroscopic cannulation. But if it is a mid-segment block or a femoral block, then again you have you don't have an option of hysteroscopy guided opening of the tubes.
Yeah, but hysteroscopy in that cases can help us for genital TB.
Yeah. And if combined with laparoscopy, we can see many other findings like suprahepatic adhesions and other adhesions.
Can be seen, and hysteroscopy for tubal block is always combined with the laparoscopy.
Proximal tubal block is the only indication where routine use of hysteroscopy, it may help you relieve the adhesion. It may actually help you cannulate the thing. Suppose patient is not affordable, you can do it in an office hysteroscopy method and just cannulate at the conval end. I'm just only talking about the conval end, this thing. Now, your 3D ultrasound, not only a 3D ultrasound, your HSG film will be very helpful in selecting these cases. Right, so that is why I have put this question very carefully. I mean, proximal tubal block is the one which actually, these are the patients where they can get away without being a laparoscopy if they're not affordable. However, it's always advisable.
I have, ma'am, I just want to add something. Sometimes on hysteroscopy, the blockage we get can also be because of the spasm.
Yes.
It can also be because of the spasm. Which the females go through because of the pain during the procedure.
It is not only spasm, sometimes a small clot or something may also get obstructed there. So with the flow of water, it actually gets cleared.
Dislodged. Right? Yeah. Yes. So I think for tubal blockage, hysteroscopy is always done with laparoscopy, along with laparoscopy.
So the NICE guidelines 2013 also point out towards the same, that hysteroscopic treatment definitely helps in proximal tubal blocks, where the diagnosis can actually be either be confirmed or it's an aided it helps in the diagnosis. For women with proximal to a hysteroscopic cannulation will improve chances of pregnancy in infertile women. So these are the cases where if you are not able to perform a laparoscopy, but your HSG will give you a good clear guideline that conval blocks will actually get relieved by hysteroscopy alone, right? The next scenario that we often see is a very difficult embryo transfer. A 30-year-old woman comes to you who has undergone 2 IVF-ET cycles. First cycle was a fresh transfer where 5A grade 1 blastocysts were transferred. There was a history of very difficult transfer. She failed in this cycle. Second cycle was a frozen embryo transfer, natural cycle in view of previous difficulty encountered. The clinician also planned to do it under anesthesia. Again, it was a difficult transfer. Difficulty in negotiating through the os was written on the case notes. She failed to conceive in the second cycle. Now she still has her embryos left. She was obviously a good responder. How will you evaluate and proceed further?
Yeah, these are the indications for a pre-IVF hysteroscopy.
Okay, you have a plan, you have done a IVF hysteroscopy and you happen to come across a tight internal os.
Yeah, it could be stenosis, it could be symptom addition.
Yeah, when there are adhesions or we can cut the adhesions, and it also gives us it is sometimes not only a cervical stenosis, the pathway is curved.
Yeah.
Correct.
So
in such cases, we
gives
can do
us
a mock
the
ED.
idea of the path of the cervical canal. It may be
Anybody wants to add anything?
Yeah, if it is a difficult canal, then we can go for a mock embryo transfer prior to the 1 cycle prior.
That was also difficult. Suppose that was also
Okay.
difficult. What are you going to do in the hysteroscopy?
Dilatation up to number 6 Hegars we can do, so
Yes.
that we retain the dilatation and immediate, and that should be done just a cycle prior to the actual embryo transfer.
Yeah.
Mansi is there?
Yes, ma'am, I'm right.
Yes, Mansi, your take on this.
Oh, I'm sorry. I just didn't listen to the question.
Tight internal os. You are unable to negotiate during hysteroscopy.
During
Anything
hysteroscopy, well, ma'am, in my experience, most of the times in about 95% of the cases, the negotiation is quite easy and you're able to get in those rare 5% circumstances. So what we do is what our practice is that we do sounding to see the root, and then we gradually dilate with the Higgins dilators, and then we are able to negotiate the cavity.
Okay, so I have observed over my 10 to 12 years of practice in infertility, I have encountered negotiating through internal os twice. Now, most of the times after that, this is some of my observations that I'm putting forward is when you go through a no touch and a direct visualization technique. That is what I think Osama Shoki sir is also visualizing. What he insists is in his instrument, you start doing a vaginoscopy, and with the distension only, if the distension is good, that internal os opens. It starts opening on its own. Secondly, the direction of the scope. You follow the direction of the scope in the direction of the internal os. So with the thing, so after I have seen this step, after I have seen Osama Shoki sir performing this step, I have never seen a difficult or a tight internal os. Secondly, if there is a difficult history, would all of you put a misoprostol prior to performing procedure? Anybody has been putting or doing that?
Yeah. I'm using.
Not routinely, ma'am.
Yeah, only when we are
No, only when she is giving a history of difficult transfers, no, the negotiating through the internal os was tight. So
Then
I
that
think
can
we
use.
can use that. We can do the hysteroscopy in the follicular phase. Sometimes what happens in the follicular phase, the internal os is already quite lax. Dilatation does help, like Palomi said, using a Haggard's 6 dagger, going up to Haggard's 6 dilator, not more than that. That can also help. But this is a situation which is very, very rarely encountered. And last but not the least is cutting up of the tight internal os with scissors. Another condition where we can have a difficulty in negotiating through the os is when you expect intrauterine adhesions, right?
Yeah.
So,
Yeah.
Mansi, your take? Anybody? Follow me.
They have to cut it.
Intrauterine adhesions, first of all, we should combine always with the laparoscopic guidance. Or if you don't have a double camera to simultaneously do a laparoscope as well as a hysteroscope, then you should do under ultrasound guidance. Because if we are cutting the intrauterine adhesions, then we should know to the extent where till when we should go on cutting those adhesions. Otherwise, we can land up in perforation. So that is very important. And since we use the operative hysteroscope, preparation with misoprostol is very important in that case scenario.
Yes,
and
because the diameter of the operative hysteroscope is more. It's around 7 millimeters.
And we should do it in a follicular phase. Firstly, because the os is lax. Second, the bleeding is usually lesser when we do it in a follicular phase from the surrounding healthy endometrium. So these are few points. And then once we are done with the adhesiolysis, we should immediately put her on estrogen and progesterone cyclical for the epithelialization.
Yeah, for at least 2 to 3 cycles.
So a thick band of adhesion at the level of internal os, I think you can just proceed with the adhesiolysis and then move on at any point of time whenever you encounter any adhesion. So you proceed with the adhesiolysis. You can take the help of a scissors, and intra-op ultrasound, I think we reserve it only for grade 4 endometritis or grade 4 Asherman, when there is loss of normal tissue. Like it's difficult to distinguish the normal tissue, and there are times where you see only the ostia. So routinely when you're doing hysteroscopy, you have 2 landmarks, that you have 3 landmarks, that is both the ostia and the internal os. That is not always the picture in grade 4 endometritis. So that is when you have to, in order to avoid perforation. Otherwise, in your regular grade 2, grade 3 endometritis, I think you just carry on with the adhesiolysis and move forward. And as ma'am said, as the cavity distends, as you resect, the cavity distends and shows you the way.
And there's also a trans-elimination test where we, if it is a corneal and adhesion, and we are not able to see both the ostia at the same level, then you can simultaneously use a laparoscope. And as you go on cutting, you can see the laparoscope light through the fundal area, and that's when you come to know that, okay, fine, now I have to stop it here. So that's a very safe method to go ahead with adhesiolysis when there are dense adhesions.
Yes. It's always better to undercorrect rather than overcorrect.
Yeah.
Right. So that is the moral of the story here, whether it's adhesiolysis or this is a septum resection.
And one very important thing is we need to keep a watch on the fluid deficit as well.
Yes.
And prior only we have to counsel the patient that we may require 2 sittings instead of.
Yeah, we can go for a second look hysteroscopy in such cases.
Yeah. Actually, it appears very easy when you are performing the thing, but then you have to keep your eyes, ears, everything, all your senses open, because you have to monitor the patient saturation also while doing this hysteroscopic procedures. Whether you are doing it fibroid or you are doing a polyp or you are doing adhesiolysis, because sometimes adhesiolysis. So other complications also you have to keep in mind, right?
Yes.
So most of the things, Palome, we have covered about adhesions as well as the septum resections. Now we often come across septums that polyps we have seen. So I would like anybody to take on whether would you remove now a patient, infertile patient has come who has a small polyp.
not all polyps need to be removed. We need to see for the.
When do you plan to remove it? When will you offer her removal?
Location of polyp has to be taken in mind, especially the fundal, the ones near the tube, this ostia. These generally where they can hamper the implantation. And yeah, these are the location is most important, plus number of polyps.
Then the size. And then the size.
Size, yeah.
If you're doing a diagnostic hysterolaparoscopy for an infertile patient and you come and see, like in the picture, if you come across and see this small polyp, will you leave it as such or you will remove it?
We'll plan to remove this because this seems to be near ostia.
No, ma'am, if you're doing a hysteroscopy, then definitely we'll remove it.
Yes.
Same fitting, yeah.
Yes, because evidence also says if you are anyways doing a hysteroscopy, in that case, you should remove it because you're doing a procedure on her, right? And you should give her the best. And removal of small polyps also have served to improve the pregnancy rates, right? So this is the evidence which says that hysteroscopy is the gold standard in diagnosing these polyps. There is a good level of evidence that says TVS or a 3D TAVS is an investigation of choice prior to a hysteroscopy, which is added on to by the addition of color Doppler. So these are good level of evidences that we have that an ultrasound is much better in diagnosing polyps. Blind DNCs, please do not use for the diagnosis of polyps. And there is a level A recommendation or evidence to suggest that if it's an infertile couple, polyp removal improves chances of natural or assisted conceptions. So coming to septum, ये सबसे common है. So now what is your take on this? Munmun, Ritu?
Yes, ma'am, septum's complete
कौन से
septum.
septum को काटोगे आप? Which septum would you want to remove? A subseptate, how will you differentiate between a subseptate and an arcuate uterus?
A 3D.
MRI
3D ultrasound.
MRI is if you're not going for laparoscopy, then MRI can really help us in diagnosis. And
Mansi को बताओ मानसी क्या आप क्या चाहोगे? Follow me.
Ma'am, I think
3D ultrasound.
3D ultrasound or MRI will give us a diagnosis. It will give us the length of that septum. It will give us the thickness of indentation. And then
correct, Ritu. Ye point is the thing. Indentation that will differentiate between an arcuate and a subseptate uterus. Arcuate को हमको काटना नहीं है तो कितना indentation?
Obtuse angle, it is like obtuse and an acute.
Yes.
Septate will have
if it is a bicornate, then it will be a acute angle. And if it is a arcuate, then it will be little more. Like the dip will be wider in an arcuate uterus.
If
so
the dip is less than how many centimeters?
90.
You are talking about the angle.
2.5 to 3
centimeter. 1.5.
1.5, I think.
I think 2.5 to 3, but I'm not very sure about
Mansi
It's 0.5. It's 0.5. See, actually, for routine diagnosis of arcuate uterus, we don't really need MRI. You can very well distinguish it on 2D ultrasound alone. And in case, if you have a doubt, then yes, like they said, 3D ultrasound definitely clears the picture. So the technique is to you just simply take a good 2D picture, obtain a 3D picture from that. And on your 3D picture, you draw an imaginary line extending from one corner to the other. And then you have to measure the dip. So it's 0.5. It's taken as 0.5. And for arcuate uterus, the normal, you can see the normal tissue, the slight dip that is there. It's when you're doing your 2D ultrasound, that will be the normal, the myometrial tissue. In case of a septum, it can be a fibrous tissue. So the echogenicity will differ. That's how you differ. So,
and if the deviation is, I think, more than 1.5, it goes more towards a subseptate rather than an arcuate uterus.
Yeah.
So I think that we take 1 centimeter as the cutoff.
So arcuate uterus doesn't need to be cut. It can be left like that. There have been
definitely. Arcuate uterus does not require any kind of intervention.
So subseptate.
Yes,
Definitely
if,
need to correct
if
it.
the patient has history of recurrent abortions, then yes, a subseptate uterus must be cut, or else we can keep it. With subseptate also, a full-term pregnancy can happen.
Correct. So I think in the last this thing, Polomi spoke about estrogen and Foley's. After you have resected the septum, now how are you doing to resect the septum hysteroscopically? Are you just going to divide the septum or resect it completely, meaning from top to bottom you are going to remove it?
It's always better to resect it because if you just divide it and let it be there, it may reform, or it may cause the same problems of abortion for which we were doing it. So
it again depends on how the what is the septum is all about. If it is a fibrous, dense fibrous tissue, then we need to resect it completely. But if it is a flimsy, like it is a thin septum, then again we have to see the thickness of the septum on ultrasound prior to the procedure. And
most of the time, usually it is a thin septum in infertile patients that we come across. Very rarely do we see a dense. Dense
we can use,
so it can be just cut and
scissors. Yeah, we can use scissors and cut it.
Yeah, scissors. We can use simple scissors, hysteroscopic guided scissors.
So you need to define the end point of septum reception. That can be the point where you see both the ostia when you're at the internal
the same level.
see both the ostia in line, and also when you're cutting, then when you see the crisscross arrangement of the myometrial fibers, so that can be a clue to then that you should stop the procedure. And the most common complication that occurs is again the adhesion formation. So like I said earlier also, you need to give the post-op follow-up is very important. You need to give something to prevent the adhesion formation. So there's no clear-cut guidelines as to what is the best technique, but being an infertility person, we prefer giving hormonal therapy, that is estradiol valerate, and in these cases at least for a period of 4 weeks.
Yes, and many a times we've seen when we have put them on these hormones, they come back naturally conceived.
Yeah,
so
yes,
that improves this thing, and putting in an IUCD and Foley's is actually not recommended nowadays. There is
and it
no
increases the
leakage of-
infection rates also.
Yes, because of the infection rates, that is very high. So that was, I think, fibroids I did not cover because Kuldeep sir has actually given a very good, to the point and precise knowledge about that. So fibroid, a discussion on fibroid we would not be taking. We would simply go on to the to our take-home messages. Hysteroscopy, when aided by ultrasound, is highly accurate in diagnosing and treating infertile women with uterine anomalies. Therefore, hysteroscopy should be a part of laparoscopy for evaluation always. Routine hysteroscopy, pre-IVF, if you are doing it first time, there is no added advantage. Pre-IVF hysteroscopy is indicated in patients with RIF, which has been found to improve live birth and clinical pregnancy rates. Hysteroscopic surgeries are very effective in infertile women with Müllerian anomalies. There is no robust evidence in cases with polyps, though live birth rate and clinical pregnancy rates have marginally found to be improved. Yet we need some more data and big studies on that. So I think with that we come to the end of it. Thank you all for a good discussion.
Thank you, ma'am.
Thank you, ma'am.
Wonderful webinar.
Thank you, ma'am.
And the panel discussion is very nice and based on the practical tips. And already we are running short of time, so I am not going in very detailed thanksgiving. I just want to thank each and every participant of today's webinar. And I want to wholeheartedly, and I want to thank our speaker, Dr. Kuldeep Jain, Dr. Resha Ratnani, and Dr. Mansi Jain for very wonderful and elaborate lecture on their topics. And I want to thank all the panelists and moderators of the panel discussion, all the chairperson, and at the end, I want to thank all the attendees of this webinar. Thank you very much. Thank you very much.
Thank you so much.
Thank you, ma'am.
Thank you.
Thank you so much, ma'am. Sorry to disturb, but can I please request everyone to open their camera so that we can have a picture?
Yeah.
Thank you so much.
Thank you. Thank you, everyone.
Okay, good night, everyone.
Good night, ma'am.
Good night, ma'am.